So I have great pleasure in inviting our first speaker, Aparna Mukherjee from India, who's going to speak on ensuring the reproductive and sexual rights of child brides in rural India. It looks a long way to go, so we're very interested in that. And she'll have 15 minutes, and we have our liaison person who's going to be holding up some cards for you. Aparna, you can kind of look over and you'll see 3 minutes to go, or 1 minute to go. Thank you.
Thank you, chairpersons, and thank you for making me sound like I have a long experience, but I'm just a young researcher from India, and I've been actively working on gender and child marriages and female feticide. But I'm very glad that I'm here to present my paper, and I really promote evidence-based research, and probably this would give our respectable audience here a chance to know where we stand now. With this, I would like to say the title of the paper is Ensuring the Reproductive and Sexual Right for Child Brides in Rural India. Looks like a way too far. Unfortunately, it gives a very gloomy plight of the child marriages or the child brides in India, and we would come to know in the process why we have titled it so. It is co-authored with Professor T.V. Shekhar. Though child marriage has been recognized as a practice against human rights, and it has been internationally mentioned, even India has our laws which has prescribed the legal age at marriage for girls as age 18, minimum age as 18, and for boys it is 21. We have Child Marriage Restraint Act which was revised in 2006, but unfortunately still it remains a common problem. Even globally, like according to the UNFPA 2014, if you see that many countries still have a very high percentage of child marriages, and but 67 million girls get married below the age of 18 years worldwide, of which 33 million is alone in South Asia, followed by 40 million in Africa, and the 6.6 million in Latin American and Caribbean countries. And South Asia alone stands for 33% of all the child brides. Now let's get closer to see what is the situation of child marriage in India. According to a latest report by UNICEF 2014, it says women of age group 20 to 49 of that, half of the married females were married below the age of 18 years. The recently conducted census 2011 says the median age at marriage for urban women is 19.7, and whereas that is in the richest quintile, which is compared to the 15.4 for the poorest women. The census 2011 says that 47.3 were married in the age group of 15 to 19 years in rural areas, whereas 29% in urban areas. So if we convert that into numbers, it's a very large number, and that cannot be ignored. Like, but how does this all matter to me? To us, in fact. Rather, because if we see this large number of girls, they are ignored in the policies of the Indian policies that we have, whether it is Integrated Child Development Scheme or Janani Suraksha Yojana. They are all universally mentioned for women to provide them with reproductive health care and maternal and child health care for the 50 to 49 age group, and not particularly looking for the adolescent mothers. So just look at some of the statistics. Like 4 million babies are born to the adolescent age 15 to 19 years, and we have one of the highest adolescent fertility in India. This proportion accounts for 10% of the maternal deaths in India according to the NFHS 3. According to WHO 2013, adolescent mothers are thrice more likely to have stillbirths and pregnancy complications. And if we try to convert it into economic terms, if we could avert this adolescent pregnancies, probably India would have India forgoes annual income over $7.7 million. So it's like we are losing not only from reproductive point of view, but like from economic point of view. So with this base, we had the objective of this research was to examine the factors which make a child bride more vulnerable from attaining her sexual and reproductive health rights, and to understand the experiences and problems that young brides face that hinders their sexual and reproductive health. The study area that was chosen for this study was India has different prevalence of child marriage. If you see the states which are marked in red, they have 52 to 68% of child marriages in India. From that we have chosen Uttar Pradesh, and from that we have chosen Shravasti district, which has common boundaries with Nepal and other 3 districts of India. It has the highest prevalence of child marriage in India. Believe it or not, it is 83% of the girls get married below the age of 18 years and 53 below the age of 15 years according to the district level household survey of 3. And even the age at marriage for boys, like for below 18 is 76%, which is quite a huge number. So how the data was collected? We, through scientific sampling procedure, in the Shravasti district, we collected primary household data from 380 households where father-in-laws and daughter-in-laws were interviewed. And the age group for these daughter-in-laws were 18 to 25 years who were married below the age of 18 years. And they were cohabiting at the time of the survey. And apart from this quantitative data, we also collected qualitative data using in-depth interviews and using univariate and multivariate statistical tools. Using SPSS, we have analyzed the data. So let's look at some of the profile before I go to the sexual and reproductive health of these young girls. So the 8.4% of the girls were married below the age of 9 years, 21 were married below the age of 9 to 11 years, 32 were married below the age of 12 to 14 years, and 38.2 were married below the age of 15 to 17 years. Almost 2/3 of this girl had to drop out of school, 27% had conceived in their first year of marriage, 58% were already mothers by the age of 16 years, and 71.2% they reported to experience physical violence, and 88% were forced to have sex without their consent. So this, now you can understand that these young girls who are not informed and have knowledge and not trained for this life skill, that make them so vulnerable and they face such problems. Now we had range of questions on sexual and reproductive health, and using those questions we have later made a composite index, which I will go later. So 12% said they had consensual sex, 17% said they had experienced coercive or unnatural sex, 6.9%, almost 7% said that they have experienced sex during their periods, and 33% said that they have experienced sex during pregnancy. In India, we do not have a law for marital rape, and that is why it is not recognized or widely spoken. And also, the reason is because of the cultural construct, it is not highlighted either. Let me just give a narration of this young girl who is 18 years and married at 13. The names have been changed for research ethics. I was 13 years and I started living with my husband, who was 5 years older to me. He was an alcoholic. My husband wanted to make love to me all the time. I was young and weak. I opposed him. He used to beat me, stopped giving me food, even tortured me during my periods. My parents stayed in a very far village. I had nowhere to return. I wish I was never born. This could be very disturbing at times, but let's see what can be done for them. So coming on to the reproductive health of this young woman, what we found that 67% had used contraception, 34% had said their choice of contraception, 41% said that they were comfortable using the contraception, 12.3% said their husbands has consulted them prior to conceiving a child, 58% said that they wanted a child when they were pregnant, and 56% said that they had a say in deciding the number of children. And with a range of questions, antenatal and postnatal care questions were asked. So only 36% had received all the antenatal care and 31% had received the postnatal care. So let's see to another insight. A woman who is 25 years and she was married at 12 and now a mother of 3 daughters and pregnant at the time of survey. She says, I don't want to have more children, but I do not have an option. My husband and my in-laws want a son. They torture me for this, but it is not in my hand. In our society, a woman having no son is called Kulnashin or family or generation destroyer, or maybe a Nagin, which means poisonous snake, or Bajin, which means a woman is infertile. No matter how many daughters you have, a woman must bear a son. I already got 4 daughters. Only I know the last one of them have died due to premature birth. Only I know how much my body suffers through each pregnancy. Within a year of death of my daughter, I'm pregnant again. I don't know when God will be kind to us and give us a son. Otherwise, I will continue to suffer all my life. So we can see it is just not the age at marriage, but the other construct, like the gender construct, like a strong preference for son or lack of social support that makes these young brides more vulnerable. We have computed a principal component analysis. We did a principal component analysis that is done to come down to a single indicator using a range of questions that can give us one single idea of a situation. For example, using these questions on sexual health and reproductive health, what we found that the degree of attainment of sexual and reproductive rights by having say or choice in sexual and reproductive health, only 10% women were attaining high sexual and reproductive rights, whereas most of the women were in the low category, 54%, and 36% were categorized in the moderate, attaining sexual and reproductive rights. Let's see to another insight. And this is a woman of 25 years, married at 11 years, and mother to 4 children. She says, I have 4 children and a big joint family. No one is educated. Sometimes our sources get so constrained that I have to think what to cook for tonight. My family was very angry at me for wanting me to go to the hospital for my 3rd childbirth. But somebody told me that I can get rupees 1400 and free medicines if I deliver at a government hospital and register myself. So the next time I was pregnant, he himself asked me to register myself with the ASHA worker and get my delivery done at the hospital. Since I'm in touch with ASHA worker, I have secretly started taking the injections that control the childbirth. My husband even doesn't know that. Since he was not willing to use contraception, I restored to this method like many other women in our village for the well-being of my family. So a financial incentive seems to be a very strong motivator for these young brides to avail the health and hospital delivery and reproductive health services. So after using statistical tools like multinomial logistic regression and controlling the factors other than the age at marriage that makes them more vulnerable, I'm not showing the tables, but I will just show you the key findings. Those women who were, women, just remember they were married below the age of 18 years and they are now 18 to 25 years old. They are at a better position and they are having better attainment of sexual and reproductive rights. Those who have availability of health center within 10 to 15 kilometers, frequent contact with natal teen, having mother-in-law with lesser age gap, women from strong parental economic background, women having at least 1 son, women having secondary and higher education, husbands with secondary and higher educations, and husbands not taking alcohol. The last insight that I would like to give that a girl, she's 19 years old and she is 16 and pregnant. She says, this is our first child. I'm very scared. I want to stay at my parents' place and not here with my husband and in-laws. My husband does not take me to the hospital. He says as long as you can feel the kick of the child, you get this morning sickness, which means everything is alright. Why should we travel so far and waste our money on hospital checkups when everything is alright? So, I will, because of lack of time, I will just come to the conclusion that this analysis identified the factors that can increase the likelihood of child brides to better attain their sexual and reproductive rights. This paper is able to provide us with insights from rural India, which often go unseen in the large-scale surveys. A nearby access to health centers, education of both the partners, strong economic support for women, lack of social support to women were identified as important factors from the quantitative study. From the qualitative study, we have identified and reinforced the lack of financial incentives, strong son preference, need for outreach of health workers, orthodox beliefs like gender norms and son preference, and alcohol abuse further detain the child brides from attaining the sexual and reproductive health facilities. I'm sure here there are many policy makers and those who are engaged in intervention programs. So from here we can get some evidence that what is need to be done. Like there's targeted programs to promote the sexual and there's a need for targeted programs to promote the sexual and reproductive rights of child brides. Accessibility and financial incentives could be geared up that would motivate them to access more reproductive healthcare utilization. There's a need to build up some kind of social support system or social network which would promote this young women to mobilize and they can access somebody within the village, and promoting earning education for both boys and girls is an important factor toward achieving sexual and reproductive rights for women. And lastly, promoting gender equal norms and valuing girl childhood positively affect the reproductive health of young women. So we have many policies which are working very nicely, but we need to integrate them, and we need to work towards adolescents, particularly who are married, and they have been left in the larger policies. So with this, I want to thank you for kindly, patiently listening to me, and my last key message would be that there is a need for targeted programs for child rights that can improve the lives of young girls in rural India. Thank you so much.
Thank you very much, Aparna, for giving us a picture of the reality of young Indian women and their lives. It is really very difficult, and it's her recommendations. One of them is related to the next paper, which is also on India, which is looking at financial incentives. Will that kind of improve the kind of enforcement of the law, the policy? So I'm pleased to invite Mr. T.B. Sekhar, Prof. Sekhar, and he's going to be talking about how to prevent child marriages in India and whether or not the financial incentive schemes will make any difference. Thank you very much.
Thank you, chairpersons, and good afternoon to ladies and gentlemen. I'm happy to present before you a study we recently carried out in India on the effectiveness of financial incentive schemes of the government in improving the education of girls and also enhancing the age of marriage. And this study was sponsored by United Nations Population Fund, India. Presently, India has around 20 conditional cash transfer schemes specifically targeting at girl children in order to improve their welfare, starting from birth registration to enrollment in pre-primary schools or Anganwadis, to immunization, primary school enrollment, and retention them up to high school level, and also delaying their marriage till 18 years. So most of these schemes, what we call it as the conditional cash transfer schemes, are implemented by both the national government and also by the state governments. These CCT schemes, in effect, basically focus on poor families by providing financial incentives based on certain verifiable conditions. If they are fulfilling certain verifiable conditions like school enrollment, immunization, marriage after 18 years, financial incentives were transferred to the bank account of beneficiary, particularly the beneficiary girls. So globally, particularly from Latin American countries, we have sufficiently convincing evidence that conditional cash transfer schemes help poor families to improve the education of the children and health care of children. But in South Asia, particularly India, we have relatively little experience implementing conditional cash transfer schemes. And we carried out, as a first part of this exercise, few years back, we carried out a desk review of 15 girl child schemes. In India, it is known as popularly called as the Ladli Lakshmi schemes. Ladli means darling or beloved. Lakshmi is, according to Hindu mythology, the goddess of wealth. So most of the schemes are either called Ladli scheme or Lakshmi scheme, implemented by various state governments, most of recent origin. Now, what I am presenting today is a recent study we carried out, taking one specific scheme of the government of India, that is called the Dhanlakshmi scheme, as a case study to understand how far the CCT schemes are helping to improve the welfare of the girls, particularly their education and age of marriage. So the three main objectives are to examine the design and execution of conditional cash transfer schemes and to identify the bottlenecks in the program implementation so we can have better programs and more effective programs. And also to understand what are the changes in the perception and attitudes of parents towards investing in girl child. Because a country known for strong son preference, how these kind of incentive schemes are affecting or have a perception on parents regarding the value of progress. And finally, to suggest how we can design a better targeted, better coordinated conditional cash transfer scheme for the welfare and well-being of girls. So the methodology adopted for this study is basically a primary survey of beneficiary and non-beneficiary households to compare the changes in their performance. We also, apart from the surveys, we also had the qualitative data coming from the case studies of beneficiary and non-beneficiary families, focus group discussions with various local leaders, panchayat members, and key informant interviews with state level program officers to down to the grassroots level, village and block level. And the survey we carried out, the scheme was implemented on a pilot basis by Government of India, Ministry of Women and Child Development in 11 blocks, and we carried out the survey in 8 blocks of these Dhanlakshmi blocks. So basically, in this study, a beneficiary household is where one girl from this household is enrolled into the scheme at the time of survey, and the non-beneficiary household is where they have a girl, eligible girl to enroll, but not enrolled into the scheme for various reasons. Now, before I get into the major findings of this study, let me take 1 minute to say what is this Dhanlakshmi scheme. As I said earlier, it is a pilot scheme by the Ministry of Women and Child Development, Government of India, started in 2008, mainly focusing on 11 districts and within that 11 blocks. Mostly these are all backward blocks with a considerable tribal population. And how the scheme is working. Parents can enroll their daughter into the scheme immediately after her birth, and they have to open a bank account in the name of the beneficiary girl jointly with her mother, and fulfilling various conditions. At each point of time, the money will be transferred to the bank account of the beneficiary. So beginning when the birth registration is done, rupees 5,000 or approximately $80 is transferred to the bank account. Then the immunization, different stages, money is transferred. When she enters into the school, primary education, money is transferred to her account. And each class up to 8th grade, money is transferred based on her performance and producing a certificate from the school that she has completed that particular year of education with 75% of school attendance. And the final benefit of a lump sum amount of rupees 1 lakh rupees or approximately $1,600 is given to the girl when she completes 18 years of age, provided she is not married and also completed at least 8th class education. So this is the way the scheme is designed and implemented. At the time of enrollment of girls into the scheme, parents need to produce a certificate stating that either of the parents have undergone sterilization. But this scheme is broadly very open, mainly focusing on the human capital investment of girl child by focusing on health, education and aged marriage. Now, the survey was carried out on these 5 states and the 8 blocks, covering around 2,150 beneficiary households and 1,806 non-beneficiary households by interviewing the parents of the girls, both either father or mother, using a structured questionnaire. And we also had sufficient qualitative data coming from focus group discussions, case studies and key informant interviews. Now, coming to some of the findings emerging out of this study, when we asked about parental intention on the level of education given to the daughters, comparing the beneficiary and non-beneficiary, so please remember that we don't have any data or benchmark survey. What was the situation before the scheme was implemented? We don't no benchmark survey, no idea about what was the scenario before implementation of the scheme. So what we are trying to do is comparing the beneficiary and non-beneficiary households with the similar socio-economic background.
Non-beneficiary.
Let me complete this presentation. I will come back. To the non-beneficiaries are the girl, they have a girl but they are not enrolled in the scheme at the time of the survey. They have an eligible girl but not enrolled into the scheme. So we are trying to compare these two and understand. We also did an exercise of propensity score matching, keeping all the factors into consideration. So we found that the beneficiary households showing better intention or higher intention of giving more education to their daughters compared to the non-beneficiary households. So beneficiary parents consider scheme is essentially aimed at the education of girls. Most parents want to give the best possible education for their daughters, but of course still there is a gap between the level of education they want to give to their sons and daughters. Half of them stated that they are willing to support the education of the girl as much as she likes to study. 3/4 of the beneficiary families felt that it is easier to educate girls now due to the Dhanalakshmi scheme because government is supporting the education of girls. They don't have to spend money. So the families feel less burden in order to educate girls, particularly in the rural, remote, poor households. Now, there are some qualitative statements were asked about regarding girls' education. As you can see, the opinions of the beneficiary parents, parents from the beneficiary households are more positive, more significantly more positive compared to the non-beneficiary households. Now, coming to the aged marriage. Aged marriage is one of the important conditions to get the lump sum amount of the final terminal benefit. So only condition that they should not get married before 18 years of age. Whether this condition had any impact at the household level. Of course, girls are still young, they are in school, they are not married, so we have to wait. But we are based on the opinion and attitude of the parents, these questions were asked. Are you ready to arrange the marriage of your daughter, even if you get a very good marriage proposal before she completes 18 years of age? And 78% of the parents stated that even if they get a good marriage proposal, they will only arrange the marriage of the daughter after she completes 18 years. This is more strong among the poor households. They consider the financial support is an important thing. But around 8% of the beneficiary parents felt that they will go ahead with the marriage compared to 12% among the non-beneficiary households. Even among the economic categories, low and middle and high income households also you will see the effect is more among the poor income households. So 14% of the parents felt that the scheme's purpose is to meet the marriage expense of the girl. Though the governmental intention is to promote the girl through her education and skill development, but the money is given at the time of 18 years, many parents believe that it is support for their marriage, to meet the marriage. That kind of a wrong perception is there among the rural parents. And 69% of the beneficiary parents intend to use the terminal benefit of rupees 1 lakh or $1,600 to meet the marriage expenses of their daughters. And one of the village leader from Orissa state said that girls from our neighborhood blocks want to get married to our area. Since the Dhanalakshmi scheme is only available in our block, their children in future can get benefits. Now, we also did an analysis of the comparing the beneficiary girl with her own elder sister and own brothers with regard to birth registration, immunization and the preschool enrollment. We found the beneficiary girls performing far better than their siblings. Now, with regard to the changes observed in the village, opinions of the both parents of the beneficiary and non-beneficiary household, they think that it will promote the education of the girls, better care for girls and families, it will support their marriage and lesser support with regard to the improvement, investment of well-being girls or boys and girls are treated equally. So it means we have a long way to go in changing the attitudes. But these financial incentives are triggering some changes, attitudinal changes among the families. So families interviewed stated that they have already observed many changes in the villages. I will skip this slide. So financial incentive schemes for girls seems to be galvanizing a process of change at family and community level. An external financial investment to girls is motivating investment by parents also. And that will also improve the care and aspiration for education of their daughters. So incentives do seems to influence perception about daughters. They feel that helping to reduce discrimination in early stages of life. So value of education appears to be universal. With the growing cost of education, incentive schemes ensures girls do not pay the price With the growing importance of education and the means to support through incentive, parents are willing to delay marriage. And with education and marriage covered, qualitative data does point to the parents seeing daughters as less of a burden compared to the earlier scenario. But the terminal benefit is considered to be for, as a marriage cost, we need to change. So we need to see in what stage and what conditions incentives can be provided. That will be the key for the success of most of the people. So incentives can play an important role in the early years of girls' life. We cannot confidently say it will motivate parents to have daughters, but at least it will ensure that they get the basic facilities. While majority of the beneficiary households willing to let girls study as much as they wish, the willingness to invest in girls' education was not apparent. And in this scheme also, after the 8th standard till 18 years, there is no financial incentive. So we need to see whether the incentives given at the early years of girls' life, whether we can give it to the later stages, high school and education. That will be far better. That depends upon the locality, the level of education and facilities. Of course, the CCT schemes also we have an assumption that the basic health facilities and basic education facilities are available in the vicinity of the villages, then only the CCT schemes and financial incentives can work. And of course, for improving the benefit of the operational part of the schemes, we have many suggestions. We need to relate the incentives at higher stages of girls' life. We need to simplify the procedures. We need to simplify the financial transfers and other things. And the scheme is more valued by the lower income households. So it will be better to target the poor households than all income households. Then last slide. What are the important reflections emerging out of this study? I feel financial incentives play an enabling role in removing gender barriers. Maybe it is slow, but changes are taking place. Incentives also dent attitudes of the parents. They feel lesser burdened with the daughters compared to the earlier scenario. Government's willingness to invest in girls' education motivates parents also to invest. Though not an end in themselves, financial incentives can drive positive changes in otherwise resistant social environment that is prevailing in many rural areas in India. So structuring the incentives is the key of the success of the program. So in brief, I would say the last sentence is that the lessons what emerging out of this study is that with the better design, better targeting, with the attractive incentives and proper implementation, the financial incentive scheme can have an impact at the village level in improving the welfare of girls and the changing the attitudes and perception of the parents. And this is very important in a society where gender discrimination is still prevalent. Thank you very much.
Thank you very much, Professor Sakhar, for your very insightful presentations and give us rich of information and then the role of financial incentive schemes in enhancing the age of marriage of girls, and then even beyond that, the upstream of the higher education level. So with that, after these two first speakers, and then I would like to open the floor for about that you have just over 10 minutes, and so we can take up some questions. Yes, please.
I would like to know from the professor that have you got any case history where the parents have got the money in the name of the girl in the bank, and they have put misuse in regarding their son. No, their son. On that money, they have been given an education to preferring their son to have an education. Have such cases have come to your...
Thank you. The professor will keep the question first, and I will take one more question, please.
Professor Shekhar,
please introduce yourself.
Yes, I'm Dr. Narima. I'm an independent consultant. I'm from Malaysia. Professor Shekhar, you very clearly said that the short-term objective is this financial support, but the long-term objective is behavioral change, attitude change. Has there been any discussion or decision made on how long should these schemes last? With the loss of 20 years, 30 years, do we have an idea when they can end?
Very good.
Okay, would you like to respond?
When we carried, Madam, your question is very relevant because many times government intend to give the financial support for a particular purpose, but households and families use it for that. The initial incentives are small in amount and the money is transferred to the bank account. One advantage of the scheme is that unlike many other schemes, there is a less scope for filtrage or corruption. Money is directly going to the bank account of the parent. But your question is relevant, whether parents are using the money, is it for the girls or for the boys or any other purpose? Our discussion with the beneficiary families and the case studies show that mostly they use it for the girls' purpose. Of course, there are one or two instances where the money is used for some other person. By and large, they feel that this money is for our daughter. And they feel that they should give education to them. So that kind of an attitude is developing. And they are also waiting for the more and more incentives to come in the future. Now the question is, how long this scheme will last? It's very difficult to answer because we have a very mixed experience in India with regard to many of these schemes. Some of the schemes started long back, still continuing. Some of the schemes with the change in government or something, some schemes disappeared. We had a bad experience from Rajasthan. One of the earliest CCT scheme called the Rajalakshmi scheme, which was discontinued after many years. But now if you look at the scenario now, more and more state governments are coming with more and more attractive schemes. The political leadership, the government realized that these schemes are useful, it is beneficial, so government is willing to invest money. They are coming with more schemes, more attractive schemes, and some of the schemes have large number of beneficiary girls enrolled, and many of the schemes are only targeting the poor households, what we call the below poverty line households. As of now, the feeling is that the schemes will continue. That is the feeling we are getting.
Thank you, Professor, for your response. And then we can take up a couple of questions, please.
I am Dr. Soumya Suri. I am from India. I am with the research agency called SIGMA. My questions are comments, whatever you call, on the first paper by Aparna Mukherjee. And I think I may be excused for making this comment, and I think I request the chairpersons to make note of this. This being an international conference, and then the first paper, it is a very, very micro level study, carried out in a village or in one district like that, and then some kind of generalization of those findings and presenting in an international conference. I think it is not, so much favorable. I think that first, Aparna, you being very junior researcher, I have 25 years of experience in research. So my feeling is that your title itself is little misleading. I think your study, I could not understand whether you are talking about DLHS and then further district, some findings, and then some qualitative case studies and FGDs and some verbatim quotations and all. On that basis, you cannot say that this is the scenario in rural India. That is too much ambitious and exaggeration of the facts. And like Professor Satter's presentation clearly indicated that there is so much positive thing happening in India, whether it is rural or tribal India. I think given that fact, you should have, even in the same village, you should have taken two cases. One family where the girls are happy, where the adolescents are happy, and in one family where the situation is not so encouraging. I think that kind of comparative picture should be presented rather than presenting you yourself that it is too gloomy. And then the indicators you presented, I was not able to follow whether they are from your study or are they from DLHS. If it is DLHS, DLHS 3 was carried out much longer. And then we also had DLHS 4. Very recently IAPS itself carried out that. And then most of the initiatives what Satters mentioned, Professor Satter mentioned, they all started after DLHS 3. So things have changed after DLHS 3. So what is the relevance and timeliness of the findings you are mentioning on the basis of that? I think these are some and NFHS. You also mentioned about NFHS. NFHS 3 is much older. I think some recent updates of the indicators will be there. Thank you.
Thank you. Please.
Good afternoon, everyone. I'm Shobhik Pine from India. I'm a public health graduate. I have a small question for Aparna ma'am. When you talk about the implications and the policy recommendation of that, there is a law of POCSO. And while these programs are being implemented, it is a violation of the POCSO which says under 18 marriages are illegal, and then you say how to make targeted intervention for child brides. So these are very contradictory. So how things should be looked at. And sir, another small question to Sekhar sir is how the change in attitude you had measured. Like you said that there was a change. So how was that change measured? What was the reference level and from which you said that there was a change? So these two were the questions. Thank you.
Yeah, thank you. And you can respond.
Thank you for your questions. First of all, I would like to clarify certain things. That this study was conducted in 2014, and it's a primary study that was conducted from 12 villages of Shravasti district. The numbers that you have been talking about, DLHS and NFHS, that was given just as a reference, and to get to the sample, to know what would be the sample size, and that is how we have gone to Shravasti district, which has the highest prevalence of child marriages based on DLHS 3. So when I went there, unfortunately I'm saying this, but we had a very scientific procedure of sampling, like how we would collect go to the sample, select the respondent, but every household had a child marriage. Though it was 83%, but every second household has daughters who were married below the age of 18 years. So I do not find it irrelevant at all to say that this is the old data and we have moved on. Yes, definitely some of the states are doing very well, and the age of marriage has been increasing in India, but still there is a large chunk and there are hotspots. That is why in my presentation I had specifically said it is a hotspot of child marriages, where not only the girls, even the boys were getting married below the age of 18 years, 76%. It's quite a huge number. So that is why our aim was to find out these hotspot areas where the prevalence is so high, and to understand how we could help these child brides and young women to ensure their reproductive and sexual health. And if you had followed the presentation, the questions were not from DLHS, the questions on sexual and reproductive health. They were questions that was designed as a questionnaire during the questionnaire preparation. And based on these questions, we try to assess what is their say and choice in decision making related to sexual and reproductive health. So, the numbers are quite shocking, but I do not see at all that it is irrelevant or it is an old study. It is and the qualitative and it's a.
I didn't say that your findings are irrelevant. I mentioned about NFHS 3 and
So that is,
not so timely.
that is taken as a reference to get down to the sample size, and not they were quoted just as a reference. And even if you see, initially I had quoted a UNICEF report 2014 which says 58%. I mean, maybe their way of calculating child marriage is different, because in India it is like our official statistics says the age at marriage has increased, so it is only 47%. But if you see the UNICEF report, it says almost half of the young women are married below the age of 18 years. So that way it is just taken as a reference. I think Shobhit, yes, you are saying, see, there are two things. There are two groups. One is boys, one are like as a policy makers or like to advocate policy. One is to how to increase the age at marriage, and it is in India it is illegal. The age at marriage is 18 years for girls and boys, as we know it is 21. One is how to delay the age at marriage. That is one part of the policy. Another is how we can make sure that those who are already married, and which is quite a high number, how we can make sure that they are better assessing their sexual and reproductive health, these young women. So this study would help us to know that, because if you have seen that there is this 10% of women who were also child brides, but they were attaining better sexual and reproductive health. So how, by looking into them, how we can have a policy that can target these child brides and help them to get better health facilities. So that is why it is not contradictory. We are not saying that we should let that age at marriage, let there be child marriages. That is one thing that we have to very strongly work on. Like as Professor Shekhar said that there are policies and which are successfully implemented and doing very well in delaying the age at marriage. But on the other side, we cannot ignore those girls who are already married and are very vulnerable to the sexual and reproductive health.
Thank you, Aparna.
I have a burning question. Can I?
Is related to this?
Yes.
Okay, very short.
Yeah. Do we have statistics on how many parents have been taken to court for letting their children marry before the age of marriage? Do we have the figures?
I don't think so.
And
Let's say zero.
or it is less than 1%. And another thing is the Child Marriage Restraint Act of 2006 that is recently, it sees child marriage as a crime and illegal, but
it was never legal. 18 years was the age for the
no,
girl.
child marriage is illegal in India.
Yeah, illegal.
Yes.
Very.
So, but the punishment that is attached to those parents or those who help in getting girls and boys married, they are very vague, like only 3 months of imprisonment, some fine. So it is not very strongly made, and so that is why it is not strongly followed.
It is more. It's 7 years or something. It's not only 3 months.
That
It is
is
a different
law.
point that they don't report. It's a community. I'm answering you. It is a community basis. So no one goes and report that this parents had married her girl under age. It is
The law has not been enforced.
No, that's what I'm saying, because they don't complain. Implementation is not there. I agree with you.
Okay, I've got my answer.
Yeah.
Yes, thank you so much. And then this is a rich of discussion, and we can continue after the session. We still have the brief response from Professor.
Otherwise, you not have been targeted, Aparna Mukherjee, don't worry. You made your research. At the same time, it is very rare, very scarce. Even your presentation has shown that Shravasti district, rural villages and only selective villages responses. This has created this type of category.
Yeah.
And as it is, based on these findings, you cannot arrive at conclusion. But agonic conditions are there across in several nations, advanced nations. We are having unwed children.
Sure. This is just a small contribution, into the research community. Thank you. Please, Professor, please.
I think why Aparna went to Shravasti district need to be answered first. Based on the district level household survey, which was carried out by Ministry of Health and Family Welfare, Government of India, Shravasti district in Uttar Pradesh having highest percent of child marriage, both among boys and girls. This is a very backward district on Indo-Nepal border. That is the reason she went to that area. Of course, she went to selected villages, did a qualitative study based on a small survey. So the reason for going is that is the hot spot. That is the reason. Now coming to the Shobhit question about measuring the change in the attitudes. As I mentioned earlier in my presentation, we don't have any scenario, what was the scenario before the scheme was implemented. The only thing what we are trying to do is comparing the beneficiary households with the non-beneficiary households, their attitude. But we are also doing a statistical exercise called propensity score matching. where we try to see that the households are of a similar nature with all the characters, and try to understand whether the scheme, particularly the financial incentives, had some impact in the attitude. So when we ask the similar questions to the parents, we find that the beneficiary parents feel more comfortable. They feel the girls' future is secure, they are getting the financial incentives, but even the non-beneficiary households even feel that scheme will be useful to them, but somehow, some reason they are not able to join the scheme. So we have used the propensity score matching analysis to try to understand the difference between these two households. We can discuss more about that.
Thank you, Professor, and thank you, Arpana. Thank you for the questions from the audience. And
Thank you. So it's, basically when we go to the next area on teenage pregnancy and adoption, it's just that we have a law on the age of marriage in India. However, it's not working, and maybe as a researcher, when we give our presentation on research, if we're talking on law or policy, then it's good to name that at the beginning. We have a law, etc., etc. What's in the law? What are the punishments, etc., offences, and is it working or not? Is it a good law or not? And I think the research, showed we're trying to find answers to how to make this law work better, and what really are the barriers. And I think we've got a good example that perhaps setting the law a little
We are
bit more.
thankful to Arpana that they have brought to our notice.
Yeah.
We will take this matter in the raw level. We are going to do
Yes.
this.
So in the next speaker, when we're moving now to the next area, it's the Philippines, another like a sort of case study or country story. And we're moving away from, we're still in the area of sort of problems of teenagers getting married or getting pregnant. Ronaldo Ong Wong from the Philippines is presenting on the policy options for teen pregnancy prevention in the Philippines. And I've asked him just at the beginning of the presentation, just to tell us about the policy scenario first, so that we know policy or more, and then he will give his analysis basically. Thank you. Ronaldo.
Thank you, Madam Chairman. But in order not to short of time, I'm going to say all these things in the context of the entire presentation, if you won't mind. I just go through it. It will be mentioned, don't you worry. Okay. So I'm here to present the policy options for teen pregnancy prevention in the Philippines. This is a policy study in its infancy, and it will be improved through your reactions. The second reason is that, just like anyone else, young people have inherent human rights that must be upheld. The third reason being that the youth are the shapers and leaders of our global future. And finally, they carry big challenges and huge potentials in their youth. Yet in a world of adult concerns, young people are often overlooked. This tendency necessitates immediate attention as it imperils young people's health, education, employment, as well as their ability to participate in society. There are laws and policies that act against the best interests of young people seeking to realize their rights, one of which is their sexual and reproductive health and reproductive rights. Some laws prevent young people from participating in decisions that directly affect them. Consequently, it interferes with young people's ability to make free decisions, gain access to quality sexuality education, and life-saving sexual and reproductive health services. According to the UNFPA, when young people realize their sexual and reproductive health and reproductive rights, they are on the path to realizing their full potential as individuals and as actively engaged members of their societies. In the Philippines, the reasons for becoming pregnant among teenagers range from early and unprotected sexual encounters, peer pressure, to lack of information about sex, breakdown of family ties, lack of good female role model in the home, and the absence of accessible and adolescent-friendly clinics. The effects of teen pregnancy are observed during the course of pregnancy through childbirth. The complications brought about by poor eating habits, unprepared reproductive organs, and eclampsia cause death among young Filipino girls. Detailed data from the World Health Organization also confirm a high and increasing incidence of fetal death delivered by Filipino mothers below 20 years old. Early childbearing also impedes improvement in the educational, economic, and social status of young women because their livelihood and employment chances are limited. Early pregnancy and childbirth also have demographic implications because of the increase in the number of dependents. The social costs of teen pregnancy revolve around public expenditures for social protection and social crimes. Sexual initiation signals the start of exposure to the risk of pregnancy and childbearing before age 18. This graph shows that sexual initiation in the country increased from 13% in 1994 to 23% in 2013 for both sexes. The proportion of females aged 15 to 19 who had begun childbearing over the 20-year period of the Young Adult Fertility Survey nationwide dramatically rose in the last 10 years, doubling from 6.3 to 13.6 in 2013. In the broadest sense, this exploratory paper recognized teen pregnancy as a government failure necessitating policy support. Specifically, this paper attempted to analyze public policy options geared toward pregnancy prevention along the dimensions of capability building, social mobilization, and service delivery using the framework of the Adolescent Health and Youth Development Program of the Commission on Population. Well prepared, for the area of sexuality education, we have this background. Well-prepared teachers who positively appreciate the value of sexuality and reproductive health education, and teachers who demonstrate comfort and dedication and self-efficacy in teaching sexuality and reproductive health education to adolescents and youth who come from varied cultures and socioeconomic backgrounds are the ones who could handle ASRH education. In a study incorporating sexuality education in the public school system, Perceptions from the Philippines, teacher respondents reported feeling ill-equipped to teach sexuality education, but they feel pressured in transmitting accurate knowledge to students, knowing that they are duty-bound to do so. The review of literature yielded that ASRH education is limited to the basics of reproductive health, relationships, and effects of pregnancy in the Philippines, and that there are public school teachers in the Philippines who would rather not teach or skip ASRH education or topics given the choice. In several focus group discussions conducted, the participants revealed that teachers are unsupported by management in terms of training and curriculum materials. Also, the training for in-service teachers on ASRH education is merely dovetailed with child protection law orientation, and the last time this orientation was conducted was in 2013. Teachers are unable to handle information obtained by students from the internet. There are public school teachers who get bullied by parents of teens who reported having a pregnancy to those teachers. The school clinics play a crucial role in disseminating correct and scientific information about early sex and reproduction. But the school clinic personnel are not trained to handle such. There are schools without clinics, and hence, some students have to be referred to nearby districts to get attended to. This proponent believes that the success of implementation and sustainability of ASR's education lies on the quality and extent of preparation teachers undergo while still in the normal school. According to futureofsexeducation.org, equipping pre-service teachers with the right attitude, in addition to medically correct knowledge and skills as provided in the Philippines Responsible Parenthood and Reproductive Health Law, will make the implementation of ASR's education in the Philippines truly comprehensive, at par with international standards, and meaningful to the learners. This policy proposition explores the need for standards in preparing teacher candidates and pre-service teachers across specializations for ASR's education. The following general dimensions in the teacher preparation standards across subject areas of specialization are forwarded, and they are in front of you. Professional attitude, culture and gender sensitivity, content mastery, professional ethics, planning and assessment of learning. The second policy option explores the need for social mobilization, a greater social mobilization. The Young Adult Fertility and Sexuality Survey, which was conducted nationwide in 2013 by the University of the Philippines, showed that the internet and cell phone technologies have become ubiquitous sources of information about sex for many young Filipinos. These technologies have also provided the means for young people to engage in sexual relationships, referred to as online or virtual friendship, thereby exposing them to heightened risks of early and repeated sexual encounters, if not sex-related violence. This proponent argues that a second policy urging telecommunication companies and social media sites to help counter teen pregnancy in the Philippines by the means it grows and contribute to the growing efforts aimed at teen pregnancy prevention or reduction would be useful. By constructively harnessing the power of interconnectivity on which most young people thrive, seek information about sex, and meet casual sex partners, young Filipinos could be influenced to acquire positive view about sex and gender relations, reproductive health care, abstinence, with emphasis to online participation in discussions that impact their overall well-being, and SRH, or sexual and reproductive health, in particular. For example, rather than convincing teenagers to buy new phones, telecommunication companies and social media sites could convince teenagers to buy the advantages of delaying sexual debut through text blasts, infomercials, and similar digital platforms. Telecommunication companies and social media sites can greatly help in effecting behavior change among Filipinos teenagers by way of generating awareness and interest about the adverse effects of teen pregnancy through behavior change communication approaches, promoting positive view about sex and gender relationships, teen pregnancy prevention, delaying sexual debut, and similar constructs, and motivating teens to want to change their behavior and intention to act on the basis of change in attitude. In the Philippines, social norms strongly forbid sexual engagement outside of marital union. Sexually active adolescents are skeptical about seeking help from healthcare professionals. The Young Adult Fertility Survey even revealed that young Filipinos are likely to try to deal with their problems on their own, or seek the help of friends or siblings of the same sex whom they trust. Young Filipinos are perceived to have poor health-seeking behavior. They don't feel the need to seek professional help because they think they are invulnerable. Others say that they have no information at all or how to seek help, and those who manage to secure health services are not satisfied. Still, others lamented that no services are available in their locality, and if there's one, it is not accessible, and that the service providers are unhelpful at all. In view of this proponent forwards another policy, a third policy option, enjoining learning institutions to transcend from youth-friendly to youth-responsive health service provisions. The proposed policy option calls for the setting up of youth-responsive health service facilities guided by the World Health Organization and Philippine standards in terms of promoting the services, accessibility, acceptability, appropriateness and effectiveness, outcome-based, and coolness. It means that the services must be cool to the youth. The establishment of youth-responsive health service facilities that focus on multimodal, tailored to the needs and cool lifestyle of today's generation of younger Filipinos hold the key to successful teen pregnancy prevention campaigns. There are 3 ways by which this policy can be operationalized. The first is by making all schools and university clinics responsive to ASRH needs. The second way is by institutionalizing U4U in schools, because in the Philippines we have this U4U. It is an initiative of the Commission on Population, and we propose that this should be institutionalized, and because U4U provide answers to questions young Filipinos are too embarrassed to ask to their teachers. And U4U uses the SMS, the World Wide Web, and the Teen Trail platforms in order to provide information in a non-threatening way. And the third is by perhaps government officials in the Philippines can look at ASRH services on wheels. Because across the Philippines, finding an adolescent-friendly and youth-responsive health service facility is equally prohibiting as finding a clinic within walking distance. So, operating ASRH services on wheels could help alleviate the soaring condition experienced by young, expectant mothers, sexually active teenagers in the Philippines, including those who are at risk, teens already living in or living in evacuation centers for disaster-stricken areas, in conflict areas, in disaster areas in the Philippines. And the preliminary stakeholder analysis of these policy options conducted tend to favor the establishment of standards for pre-service teacher education to prevent teen pregnancy prevention. Unfortunately, the perceived high cost of implementing it could be a deterrent. Results of the focus group discussions conducted tend to gravitate towards the provision of multimodal means to reach out to young people, because the participants in the focus group discussions feel that this option have the most impact in their line of work. At this moment, there is no policy directly intended for teen pregnancy in the Philippines yet. Designing policy initiatives is an art that requires careful consideration of many factors. The key challenge is whether the means of implementing the policy options will likely work in practice. by engaging more influential and powerful stakeholders and consulting deeply within the community, the policy recommendations can be assured of their correct path. There is also a need to chart a broad political and multi-sectoral orientation in approaching teen pregnancy prevention in the Philippines to comprehensively link ASRH education and social mobilization actions with service provisions in a manner that is tailored to young people's needs and lifestyles. Recently, the World Health Organization Philippines funded a study in the National Capital Region to model a strategy linking interventions with service delivery options for young Filipinos. And initial findings show increased number of adolescents seeking and being provided actually with appropriate health care from health facility and trained service providers. This particular study will be replicated in all 17 political regions in the country in the hope of determining how policies could be better crafted to prevent teen pregnancy in the Philippines. Thank you so much.
Thank you very much, Mr. Ronaldo. We've got about 7 minutes, Madam Chair says. So let's be quick. Let's see what do you think will work? What do you think of Mr. Ronaldo's proposals for preventing teen pregnancy through policy interventions? Yes, Dr. Narima, and then Madam Frank.
Not exactly a question, but I'll make it short. When I was working for the WHO around 2008 and 2009, we commissioned a study on teenage pregnancy. 17 countries contribute to 16% of teenage pregnancy. The highest were Nepal, India, Bangladesh, USA, Brazil. You can immediately see USA and Brazil were free-sex, unmarried girls. Nepal, Bangladesh, and India were married, what we saw child marriages. And very interestingly, there was one other Asian country that was in the 17. These are 17 countries, and that was the Philippines. But the Philippines' contribution was less than 1%. But there was no adequate data to show whether they were married teenagers or unmarried teenagers. So obviously, this has implications to prevention strategies, whether they're married or not married. While I'm having the floor, I asked that question early on about enforcement of the law in India. In 1994, at a conference in Delhi, I said, as a law been enforced, as any parent will put to prison? The answer given to me was, we don't enforce the law, because if we do, many of the ministers and parliamentarians will be in prison.
I would like to know. Yes, sir. I would like to know that you were telling that the teachers, public teachers, they interact with the students. Is there any counseling of the social sector also through the teenagers to tell them that how to avoid pregnancy? And what about the kids which come out of this pregnancy? Who looks after them? Are they being they get the abortions done? So I would like to know them, because in Philippines, I don't know whether the abortions have been legalized or not, still because of the your so how they face all these things?
Thank you. And we have a few more questions, and then please, and then Ronaldo will answer all of them, yeah, or comment. Any countries that have got some good practices to share, that have got a new policy that's working?
Thank you for your insightful presentation. I have one question. What is the mean age of sexual exposure in your country? Like, what is the age at first sexual exposure? And is it forced or within romantic relation? Okay, I forgot to tell my name. I'm Sharmishna from India. I'm working with Population Council.
Any other final comments or questions? Please.
Good afternoon. My name is Rina Don from UNFPA Philippines, Country Office Assistant Rep. I think from a programmatic perspective, what Roy presented now is quite useful, but just to complete the picture, we know that in the other sessions there was a citation of the reproductive responsible parenthood reproductive health law. And in that particular law, it did give a challenge to our young people because of the issue of parental consent. So we should discuss this in the context of the barrier that young people could access ASRD information, but they could not access ASRD services without parental consent or consent to the guardian. And even the way they operationalize it, government, they also do face certain challenges. The second issue that you really have to look into when you study this particular issue is the role of the local government units. We have a decentralized health environment in which the role of good governance, the importance of good governance, the role of the mayors, and how they relate to young people is a crucial issue. So this just broadens the other macro issues that have to be considered apart from the programming issue.
Can I have one? Very short.
Okay, if it's like 10-second question, yes.
One
10
of my
seconds.
country people take the floor, so I have to plan. Actually, I have nothing to do with teenage pregnancy. I'm old, 67 years old already. But I'm trying to prevent it, mitigate it, eliminate it my way. I am asking my counterparts, especially the female opposite sex, to have a forum on sex, love, marriage, and religion to detail unwanted pregnancies, including teenage. Thank you.
Thank you so much for all the comments, but Madam, with regards to the role of the guidance counselors, yes, the role of guidance counselors is very important, and they are already being included. All non-health professionals are being trained now on how to deal with adolescent sexuality and reproductive health concerns, whether in school or for out-of-school youth. And for whether forced or romantic, the young adult fertility survey did not mention that. It wasn't part of the study whether it's forced or romantic, but the age of first sexual engagement is decreasing in the Philippines. So, the statistics show that, but it's not significant. It's very small, very negligible. There are those who get pregnant at 9, having sex at 12, and yes, but the data shows declining onset at the age at first sexual encounter is decreasing in the Philippines.
What is the age?
What age?
15 to, I'm sorry?
What is the...
It's decreasing from 19 to now to 18.7.
Okay,
This is decreasing. And when it comes to parental consent, yes, parental consent is a big issue, even with the reproductive health law in the Philippines. So, how can that be addressed? I think the Department of Health is addressing that through the implementing rules and regulations to how to go about it. We cannot do anything as of this moment because it's a newly enacted law. It was enacted in 2012. It's a new law. And with the role of the local government units, yes, the local government units, because health is a devolved function to the local government units, yes, the local government unit, the rural health units, barangay health stations will be included in the policy formulation.
Thank you.
What about the kids which come out of that pregnancy? Who looks after them?
Children are one by one.
The children, not the kids, but the children.
In the Philippines, centers for women, they can be placed for adoption. I'm not sure about the. I think you already mentioned social protection, and social protection for young mothers is becoming another dimension for helping. If not, maybe it could be condoning, it could be tolerating the pregnancy, but social protection is also a big issue for teen moms in the Philippines.
Thank you, Mr. Wong. Actually, I believe that we can continue our discussions until Kaladina. And then so, with that, I would like to try me to give a round of applause to thank you very much, my co-chair and the three distinguished presenters, and especially my appreciation goes to all the audience, and this is very lovely audience, and then who gave us a very dynamic environment even before the start of the presentation. Thank you very much, and so thank you. Yeah, have a nice evening.